Chapter 18, Ambulatory Surgery Centers. And the objectives for Lesson 18 is 1. Explain the revenue cycle of reimbursement systems for ambulatory surgical center claims. 2. Understand the ambulatory surgery center billing process using by ambulatory surgical centers. 3. Discuss the importance of medical coder and biller rules in reimbursement. 4. Describe the components of the outpatient prospective payment and ambulatory surgical payment systems. 5. Recognize the features of the relative value unit and factors of the resource-based relative value scale payment system with the emphasis on the ambulatory surgery center rates. 6. Explain the role of the International Classification of Diseases, 10th Revision, Clinical Modifier, Coding System, also known as the ICD-10-CMs. 7. Explain the role of, and it should be current procedural terminology, 4th Revision, Procedure Coding System, CPT-4, and ambulatory surgical billing. 8. Identify the role of a healthcare common procedural coding system, HCPCS. 9. Describe the significance of assigning modifiers. 10. Define payment status indicators and their use in the Medicare ASC reimbursement process. 11. Understand the impact of local coverage determinations and national coverage determinations in the ASC reimbursement cycle. 12. Recognize and assess the reimbursement methods used when determining various payers for ambulatory surgical services. And 13. Identify the ambulatory quality reporting measures and the effect on the ASC payment rates. History of ASCs. In the past, almost all surgery was performed in hospitals. Surgery was scheduled in advance with preoperative tests such as blood work and x-ray examinations done during the initial inpatient stay. Surgery was done on the second inpatient day and recovery added to the length of stay. And since ambulatory surgery centers have increased over the past 4 decades, and the reasons for the growth is reduced healthcare costs for patients, providers, and payers, expansion of types of surgeries and services performed, and national technological advancements of healthcare for ambulatory surgery facilities. Types of ASCs. So the first type is an independent ASC. It's a freestanding and privately owned. It's not integrated or directly associated with the hospitals, and it's not included in the hospital cost report. Then your hospital-based ASC, it's affiliated with or owned by the hospital, and it can be freestanding or located within the hospital. Now, both types must be certified. Most state requires licensure and the Accreditation Association for Ambulatory Health Care. Now, initial certification of an ASC will involve a survey with compliance to standards to meet Medicare and state regulations. Certification and licensure must be maintained on an ongoing basis. ASC Payment System. The ASC Payment System is used when paying for covered surgical procedures and the ASC facility services that are furnished in connection with the covered surgical procedure. CMS updates the OPS/ASC regulations together in one rule annually with public comment periods before implementation of the final rule. Medicare maintains and updates the covered procedures list defined by CPT and HCPCS codes of all services offered in an ASC. Medicare Part B covers the outpatient and physician-based ambulatory services. Providers primarily receive reimbursement via hospital outpatient prospective payment system or the Medicare physician's fee schedule, and payments are based on the Medicare rates. Services are identified using HCPCS codes, and the ASC must accept Medicare's payment as payment in full for defined ASC services. Payment for ASC services. Payments made to the ASCs from private insurers are based on the contract the facility has with the payer. Insurance carriers use fee schedules that are contracted and maintained on an annual basis with the ASC. The ASC must include charges for the package it services into the charges reported for the separately payable services with which they provided. Your facility payment has the ASC list of covered surgical procedures, the Category 1 CPT codes within the surgical range of CPT codes 10000 through 69999. It includes Level 2 HCPCS and Category 3 CPT codes that crosswalk to Category 1 codes. The surgical procedure may be covered, but not covered when performed in an ASC. Procedure or service must be considered medically necessary. And the Medicare's ASC reimbursement includes services performed by the facility and the cost of the physician's professional services. Medicare will not pay for surgical procedures in an ASC if the procedure meets any of the following criteria for exclusions: is on the inpatient only list, which approximately 1,700 procedures, possesses a significant safety risk to the beneficiary, typically requires active medical monitoring and care past midnight, directly involves major blood vessels, requires major or prolonged invasion of body cavities, generally results in extensive blood loss, is emergent in nature, is life-threatening in nature, and commonly requires systemic thrombolytic therapy, and can only be reported using an unlisted surgical procedure codes. Under RVRVS, CMS assigns relative value units, the RVUs, to each surgical procedure using three factors that affect physician costs: the amount of the physician work involved, practice expenses, and malpractice and liability insurance. The work RVU, practice expense RVU, and malpractice RVU are each multiplied by separate geographic practice cost indexes, also known as GPCI. The adjusted RVUs are added together and multiplied by the physician's fee schedule, CF, to calculate the total payment rate. The physician's payments are based on Medicare's payment based on the MPFS, and is generally not packaged. Your Medicare physician's fee schedule will be determined by RVRVS, and the payment modifiers affect the specific payments. Separately payable services. In determining the ranking of procedures for the assignment of the multiple procedure reduction, payment is based on the lower of the billed charges or the ASC payment amount. Services covered under Medicare may be furnished in an ASC, but are not considered ASC services. Services are covered and paid for under the applicable provisions of the Medicare Part B. Multiple surgical procedures, with 100% of the highest paying procedure, 50% of the applicable payment rate for other ASC covered surgical procedures. Hospital outpatient prospective payment. Hospital outpatient services that do not fit into an APC is diagnostic and non-surgical therapeutic procedures, blood and blood products, clinic and ER visits, certain preventive services, and some drugs. The comprehensive APC payment model is being developed to simplify reporting and payment provisions for high-cost, complex outpatient procedures by accounting for all costs and component services that are typically involved in the provision of the complete primary procedure. Revenue cycle management. Pre-admissions. The insurance carrier will require the patient's demographic and insurance information, including the policy's effective dates, the date of the planned surgery, and the reasons for the procedure or services. Medical necessity, the use of services and or supplies as determined by the insurance corporation's medical director or his or her designee. It is essential for the determination of the patient's coverage and verification of benefits. For services to be considered medically necessary, it must be reasonable and necessary to treat the patient's medical condition or diagnosis. Each insurance provider will have special requirements for the information provided on the claim form and the effective due dates for submission. During that pre-admission process, the verification of eligibility of insurance benefits will be verified. And remember, the pre-authorization is the pre-certification or referral from the insurance company. Services, again, must be medically necessary. Reimbursement process. Deadlines in which appeals can be submitted vary among insurers. Often, the billing and collection contractor will manage this process. After payment is received, the review of the RA, which is the remittance advice, to ensure correct amounts. Collections is potential for added staff costs and legal complications. Many ASCs hire billing contractors, and payment is arranged early, and the billing contractor can follow up. Appeals is the insurer must report why claim was denied or reimbursed at a lower charge. Must state how and when their decision can be disputed. Other types of reimbursement. With self-pays, collection can require significant work and cost. Policy and fee schedules should be provided to the patient before visit. When the healthcare provider signs a capitation agreement, a list of specific services that must be provided to patients is included in the contract. The amount of capitation will be determined in part by the number of services provided and will vary from health plan to health plan. Capitation is the fixed amount of money per patient per unit of time, and it is paid in advance. The fee-for-service is healthcare's most traditional payment model, in which physicians and healthcare providers are reimbursed by insurance companies and government agencies, third-party payers, based on the number of services they provide or the number of procedures they perform. Payments are unbundled and paid separately each time patients have a procedure in the ASC. It is the most common, as I said, and services are paid for after they are received. Medical records for reimbursement. It requires a complete patient chart, which includes the medical record, payment and benefit plan agreements, and insurance identification, verification, and authorization. The coder reviews the record and assigns the appropriate CPT and HIPAA codes, the IC10-CM diagnosis codes, modifiers, status payment indicators. This will require knowledge of ASC coding in accordance with ICD and HIPAA coding rules, proper billing procedures from both Medicare and private payers. Now, audits are on the increase and will continue to be a factor in coding and billing compliance. The first listed diagnosis, the condition treated or investigated during the episode of care, is documented by the surgeon and located on the operative report upon the completion of the surgery. Often, this is called the postoperative diagnosis. Now, with your diagnosis coding, all diagnoses must be coded according to the ICD-10-CM guidelines. It'll have the admission, the initial, preoperative, first listed, postoperative, secondary, and additional diagnoses. For procedure coding, it's the first listed procedure can be therapeutic or diagnostic. It's the highest paying procedure. CPT codes entered in descending order or reimbursement, and the provider must document diagnoses for all services performed. Billing. Scrutiny of coding compliance, which requires knowledge of ASC coding in accordance with ICD and HIPAA coding rules, as well as proper billing procedures from both Medicare and private payers, has been on the increase in recent years and will continue to be a factor in coding and billing compliance audits in the future. With Medicare, the global period, and what is included in that is the preoperative, the intraoperative, and the postoperative services. Remember that preoperative is before surgery, intraoperative is the surgery, and postoperative is after. Separate billing not allowed for visits or services included in the global package. The APC must be calculated, and the ambulatory surgery fee schedule is used. Claims management and healthcare claims submission. The Administrative Simplification Act, ASCA, requires that all initial claims reimbursed by Medicare be submitted electronically with limited exceptions. ASC claims are different from hospital claims. The appropriate billing form depends on the type of facility. ASC claims will be reported to Medicare, Medicare Advantage plans, and Medicaid using the CMS 1500 or the 837P form. Professional charges are also filed on the CMS 1500. On your CMS 1500, Box 23 or Field 23 is where you put the prior authorization number. Field 24B is place of service, and you'd enter a 24 for ambulatory surgery center. If you're not sure of the place of service number, you would just look in the beginning of the CPT manual and you will find all of the place of service codes, and there are at least 99 of them. Field 24D is the ASC modifier. Now, hospital outpatient surgery claims will be reported with the UB04 or the 837I form. The UB04 is often used to file medical claims to the other payers. On the UB04, Box 4 is the bill type for submitting claims. It is represented by the 83, and X is just a placeholder. The first digit denotes the type of facility, which is 8, which is a special facility, hospital, ASC surgery. The second digit denotes the bill classification. So 3 is outpatient. And then the third digit signifies the frequency in which it's represented by the variable X. 1 is admit through discharge claim. 7 is replacement of prior claim or corrected claim. And 8 is void or cancel of prior claim. Most often, the third digit is a 1 for admit through discharge claim. Your Box 42, 490 are where your revenue codes that are used to report the ASC care. Modifiers. Procedures and services are often complex, so modifiers provide additional information about the procedure. The CPT modifier can describe whether multiple procedures were performed, why that procedure was necessary, where the procedure was performed on the body, how many surgeons worked on the patient, and other information that may be critical to a claim status with the insurance payer. The CPT appendix modifier approved for ambulatory surgery centers, hospital outpatient use. The Medicare modifiers RT is right side, LT left side, TC technical component. 52 is used for coding reduced services for discontinued radiology procedure and other procedures not requiring anesthesia. 59 is a distinct separate procedure. Modifier 73's procedure is discontinued after preparation for surgery. Modifier 74, procedure discontinued after anesthesia administered. Modifier FB is device furnished at no cost or full credit. Modifier FC, device furnished at partial credit. Modifier PA, wrong body part. Modifier PB is surgery, wrong patient. PC is wrong surgery on patient. Modifier PT, colorectal screening converted to diagnostic or therapeutic procedures as surgeries. And modifier GW, surgery not related to hospice patient's terminal condition. Now with the Medicaid modifier SG, that just identifies that the claim is an ASC claim. And then your other insured modifiers, you've got your modifier 50, which is bilateral. RT, like Medicare, right side, LT, left side. Then you got your E1 through E4, and so on and so forth. And remember, there are a list of these in the CPT manual at the beginning for a more short version of them. And then Appendix A are the ones for the other insurance modifiers, will be in the back of the CPT book. Status payment indicators. Every CPT HCPCS code has a status indicator in the OPPS. It provides information about the procedure, whether or not it is covered under the OPS, subjected to discounting, and inpatient procedure only. Discounting is when reimbursement to the ASC is reduced. National Correct Coding Initiative edits. Accurate coding and reporting of services are critical aspects of proper billing. Although some payers may follow the NCCI process, most pay a case rate for the service according to their respective contracts. It is recommended that the biller review the specific contract to see if the NCCI ruling is applicable or if the payer uses their own. The National Correct Coding Initiative controls improper coding, leading to wrong payment in Part B claims. There are bundling instructions that would apply. Only the more comprehensive code is covered. Physician NCCI edits apply, and it contains the PTP edits for physician and practitioners, or the PTP edits for outpatient hospital services. Local coverage determinations and national coverage determinations. Contractors review claims on either a prepayment or post-payment basis, regardless of whether an NCD coverage provision is an interpretive manual or the LCD exists for that item or service. The National Coverage Determinations, the NCDs, describe circumstances for Medicare coverage nationwide for specific service, procedure, or device, and defines conditions to determine if service is covered. The Local Coverage Determinations, the LCDs, is decision by Medicare Administrative Contractor, MAC, regarding whether to cover a particular item or service. MAC is on a wide basis. It's used when there is no NCD or there is a need to further define an NCD. ASC Quality Reporting. The Ambulatory Surgery Center Quality Reporting Program. The ASCs report quality of care data for standardized measures to receive full ASC payment rates. It's value-based purchasing for the VPP program. And the ASC quality measures, goals for quality improvement and accurate decision-making, and efficiencies and patient satisfaction. And this concludes the lecture for Chapter 18, Ambulatory Surgery Center.